Now we're continuing chapter 35. Last time we went through the nose. We talked about air coming in through the external nares, vestibule, meatices, and internal nares. And now we're going to continue the flow of air into the pharynx. So the pharynx is a cavity that is behind your nasal cavity and your mouth, extending a bit into the neck. And there are three parts to it: nasopharynx, oropharynx, laryngopharynx. Now, the three pharynx areas are named for the structures they are near. So first off, nasopharynx is behind the nasal cavity. The oropharynx is behind the oral cavity or mouth. And the third one, laryngopharynx. This one's a bit differently placed with respect to its name. Laryngopharynx is not so much behind. I usually describe it as being somewhat above the larynx. Larynx being a structure we'll talk about in the next slide. So three parts. When inhaling, air goes from the internal nares through these structures in order: nasopharynx first, oro, laryngo. And for the pharynx, there's not much in terms of structures in the pharynx. There is, like all the other parts of the respiratory system, mucosa to make mucus. Aside from that, the only other major structures are the tonsils, which we talked about a bit already in Unit 1, Chapter, I think it was 31. And so there are the pharyngeal tonsils. Pharyngeal are in the nasopharynx. And then, as it says on the slide, the oropharynx has both the palatine and the lingual tonsils. Laryngopharynx does not have any tonsils. And anatomically, that's really all there is to the pharynx. It's pretty boring, not much to it. So next up is the next structure, the larynx. So larynx comes after laryngopharynx in the flow of inhaling air. And the larynx is positioned in the neck. It's in the neck. Specifically in the front of the neck. And we'll look at the anatomy. First off, if you haven't heard of the larynx before, the larynx, this is also called the voice box. It's in the neck, the front of the neck. It has a few parts to it, mainly composed of the walls, although there are a couple structures on the inside. And if I were to draw this from a side view, we'll see a picture of it in just a moment. But so I can talk about the structures on this slide, I'll draw out a little drawing. This will be a side view. So if you look at the larynx from the side, it'll look something, let's see, so I'll have this thing, then a piece kind of bulging out and down, and then thing here, move it down a little bit. Okay, this is roughly the shape of the larynx from the side. Let's see, I'll move this up so I can have the full look. And okay, from here, I'll just for positioning, this red thing is the back of the tongue, so you roughly know where this is. Distinguish this. Okay. We'll put this here actually. Or maybe I will just put like a division like this. Okay. So in the neck, at the larynx, there's a side view. Larynx has a few parts to it. First off, I have that term there, vestibule. Like the nose, the vestibule is just the first open part to the larynx. So I'll draw some kind of dotted lines. Roughly speaking, this is very rough, it's not super exact. But the vestibule will be roughly something like this. Vestibule. Again, not super exact placement, just to emphasize it's the first area, not the whole thing. Now, inside the larynx, there's of course, and I'll do this on the slide, there's of course some mucosa, as all the other parts have. And otherwise, the only major structures are what we call the folds. So the folds are literally like folds of tissue inside the larynx. Let's see, what color do I want to use here? I'll use black, I guess. So I'll put folds in black, one up here, just inside the vestibule, one just below it, two folds. I should say two pairs. There's a side view, but there's really, for each of these, the one on top, the one on bottom, there's one set on the right, one set on the left of these folds. The upper folds that are in the vestibule are named for the location. They are the vestibular folds. And the bottom folds outside the vestibule are the vocal folds. Now these folds, they come in from each side of the trachea or the larynx. And there's a couple things that they do. One thing, the folds can close the larynx, so they can literally like close the larynx, come from either side and close. But also the vocal folds specifically, the vocal folds are also called the vocal cords. And so I'll put this on the slide, I guess, because there's not that much room on the whiteboard right now. The vocal folds or vocal cords are responsible in part for producing speech. The vestibular folds, not much of a role in making speech, mainly the vocal folds. And those are the major structures inside of the larynx. Now, the other major structures we're going to look at is going to be mainly the cartilage framework of the larynx, the cartilage framework. Of which there's several pieces. Here's a side view, a little bit better than my drawing. So a few things I want to look at in the side view. Again, I want to point out, here's the tongue above. So that's your mouth up there in the front. We have the larynx in the neck. And larynx in the neck, I'll bound this out, is roughly within this boundary. This, is that a rhombus or a trapezoid? Well, in that shape. Going from about the, just below the tongue to about the top part of the thyroid. We can see the two fold pairs, vocal and vestibular. And a few things I want to point out here. First off, you'll notice in the neck, there's two tubes in the neck here. I'll try to outline this. It's very red on here, so I'll try to use a different color. I'll use, what'll stand out on this? I'll use, I guess, black initially. So the larynx leads to a tube in the front of your neck. But there is also a tube going along the back of your neck. So we've got two tubes. For right now, I'm going to focus on the front tube, or on the larynx, which goes to the front tube. And these two tubes are important because, let's see, actually, the one isn't named here. So the front tube, where is it on here? The front tube is the trachea. And the trachea is going to lead down to your lungs. That's where you want to go. And the back tube, the tube in the back of your neck, then is the esophagus that goes to the stomach, which is not involved in breathing, Now, the reason I point this out here is that for the trachea, one structure I want to look at is this first structure, which is the epiglottis. The epiglottis is a doorway, a hatch that can close and open. Close and open, close and open. When the epiglottis is open, air can go into the larynx. But if you're eating or drinking something, we don't want food and drink to go into the larynx. We want it to go into the esophagus, which is in the back. So the epiglottis closes to prevent food and drink going into the larynx. And that's mainly what I wanted to say on this view. We'll go to some other pictures that will show the trachea from other, or the larynx from other viewpoints that'll help us look at the other structures. This is a structure from above, a superior view. And here we can see clearly the chords on either side. I'll outline this. Let's see, it's red, so I'll use black again. So here we have the chords along either side that can open and close, as well as vibrate to modify sound. Here's some real chords in the neck. And here's a look at the larynx from the front. Larynx goes down to this line. So above this line is larynx. Below it is the trachea, which is the next part we'll talk about. So for the larynx, we're going to look at the larynx. We're going to look at the cartilages that make up the larynx framework. So from the front, we have two major cartilages. We have the thyroid cartilage, which is this big shield on the front. Thyroid cartilage is only at the front, protecting the front. It is the biggest larynx cartilage. And it has a bump on it that makes the Adam's apple in the neck. That's the thyroid cartilage. And secondly, we can see below the thyroid cartilage, the cricoid cartilage. Cricoid is below thyroid cartilage. And the cricoid goes all the way around. It's a full ring. That's what I want to show on the front view. Here's a back view, posterior, which is actually quite open. And so from the back view, we see some other cartilages. Epiglottis is a cartilage. We can see it clearly. There's also two other pairs we see, corniculate and arytenoid. The arytenoids are these roughly, I think of them like A's that are filled in. Those are arytenoid. And the corniculate cartilages are on top of the arytenoid. They're on top. And something to say about these two, cornicula and arytenoid, this isn't really shown in this view very well, but the cornicula and arytenoid, they are anchor points for the folds in the larynx. Anchor points. That's what we can see from the back view. So in total, there are 9 cartilages for the larynx. 3 single pieces, thyroid, thyroid cartilage, epiglottis, cricoid cartilage. Those are all single pieces. But the rest of the pieces, the other 6, come in 3 pairs. A pair of arytenoid, pair of corniculate, and a pair we didn't look at because we couldn't see them, cuneiform. The cuneiform cartilages, we couldn't see them. They're kind of hidden. You have to look kind of inside the larynx to see them clearly, but they are part of the larynx as well. Let's see, this is just to have a nice list. I think I talked about everything I wanted to say about these. Okay. And aside from the cartilages, the other major components of the larynx are the muscles. There's 2 kinds of muscles for the larynx. There are intrinsic, which are inside the larynx. As it says, they control the vocal folds, which helps to modify speech. And I have here, they can open and close the glottis. Now, glottis, that's just the area around the vocal folds. Just the area around the vocal folds. That's why the epiglottis is called that. It's epi, above the glottis. There are also extrinsic muscles, which are outside the larynx. And the extrinsic muscles help to move the larynx as a whole. So the larynx can be moved somewhat up, somewhat down, moved around a little bit, which can also change the voice. And for functions, we talked about the functions already. Larynx, part of the airways, conveys air, and helps to make your voice. And that was the first half. Now, everything up to this point, from external nares to larynx, that is the upper respiratory tract. The remaining structures that we're going to look at are part of the lower respiratory tract, the structures inside the thorax. So we'll look at trachea, bronchi, bronchioles, alveoli. Talk about parts of the lung, a bit about the thorax in a general sense, and a bit about disorders. Okay, now lower respiratory tract. Up to this point, to review the flow of air, went from when inhaling, external nares, vestibule of nose, meatices, interior nares, nasopharynx, oropharynx, laryngopharynx, larynx. Now going into the lower respiratory tract, the trachea. So your trachea, that is the same thing as your windpipe, same type of thing. It's in, as we discussed, the front of your, well, technically it starts in the neck, but goes into the thorax along the front. And for the trachea, structurally not that complex. The trachea is basically just a tube, just a straight tube. Has a few layers of tissue, adventitia, that's mainly connective tissue on the outside. There's smooth muscle. Actually, I may as well write this down. Let's see, I'll put this here, here. Adventitia, basically some connective tissue. Smooth muscle, which can constrict or dilate your trachea. There are also C-shaped cartilage rings, sometimes call them C-rings. These C-rings help to keep the trachea, help keep it open, as well as give it some structural integrity. They're called C-shaped or C-rings because the C-rings are open at the back. They don't go all the way around. There's a reason for that we'll see, I think, on the next slide. And of course, like all the other parts, trachea has some mucosa. Function of trachea, just to conduct air, just a tube that conducts air. Here's a look at the trachea. So on the picture on the left, going from larynx down is the trachea. On the right is the trachea from the back. And you can see the C-rings don't go all the way around. The C-rings don't go around the back. And there's a reason for that. Here, there's a look at the trachea from above. And so in this view, well, I'll point out the compass. The top is anterior, bottom posterior. We have the trachea and the esophagus. Now, the reason the C-rings don't go all the way around is that if you're swallowing and food is going through the esophagus can extend a little bit into the trachea. Not much, but it gives it that little extra room that helps to prevent choking. Which is why the C-rings shouldn't go all the way around. should not go all the way around. And here's a visual look at the mucosa. Similar to what we looked at before, mucosa has the cilia, the goblet cells for making mucus. And for this, I want to bring up a disorder, the so-called smoker's cough. So smokers might develop a characteristic cough, and that comes about from the chemicals in smoke, like cigarette smoke, will, I don't want to say this exactly, will inhibit the cilia, meaning that the cilia won't move very well. And if the cilia can't move very well, mucus stays in the airways. And so to get the mucus out of there, your body tries to cough to force the mucus out. That is the smoker's cough. Last thing about the trachea, some medical stuff. I said before that the trachea has smooth muscle, so it can constrict and dilate. Sometimes that smooth muscle constricts so much that the trachea closes up completely, and then you can't breathe. This could be for a few reasons. Maybe it's because of allergies. Maybe it's because of drugs. For example, certain anesthetics they might give you for different kinds of surgery. But whatever the cause, we have two main ways to force the trachea open if that happens. One is endotracheal intubation, shown on the left. And endotracheal intubation, this is shown, but this is a tube, hence intubation, going into mouth and then into trachea to keep it open. That's one. The other procedure is the tracheostomy. That's the same thing as the tracheotomy. You can spell it both ways. And the tracheostomy, this is cutting a hole in the neck and inserting a tube into the trachea. Normally this hole, as is shown in the picture, is cut below the cricoid cartilage. It's possible to cut it between the thyroid and cricoid cartilage, between thyroid cartilage and cricoid cartilage, but normally you cut it below the cricoid cartilage. And for these two procedures, they have pros and cons. For the endotracheal intubation, the pro is you don't need to cut anything, so less damage. The con is that if you got the tube in your mouth, you can't eat or swallow. So you have to get nutrition through an IV. for the tracheostomy, the con is you have to cut the neck, so there's damage. The pro, though, is that with the mouth being unblocked, you can eat, swallow, and even talk uninhibited. Which one you use, that depends on the particular situation. If you're uncertain about that, I suggest asking a doctor which situation you'd use which one in. And here's a look at the tracheostomy from the front. There's the hole the tube goes in through. There was the trachea. Now the last set of tubes before the lungs are the bronchial tree. And so for this, all the parts are listed here. Well, I'll need a picture to talk about these. Let's make it as big as possible for right now. So I'll look at this from a front view. That will be the easiest. So I'll make a box here for the larynx. Just call this the larynx. And we have the tube coming down from the larynx. That's the trachea. Now the trachea, or well, I should say up to this point, the flow of air has basically just been one long tube. From nose to trachea, that's basically just one tube. But there's a problem that eventually the air has to go into two lungs. So you have a lung on the left and a lung on the right. These are lungs. It's a lung. Here's a lung. And so now, after the trachea, we have to make a split. So the trachea is going to split into two tubes, one going into each lung. So these two tubes, I'll make this picture small for a second. Oop. These two tubes are the primary bronchi, a left and a right. So these are primary. Actually, I'll need some extra room on here, so I'll just use numbers. So use 1 and degree symbol for primary bronchi. There's left and a right. And those are the first tubes entering the lungs. Now, to exchange air efficiently, which is our ultimate goal, the tubes going to the lungs have to branch. The lung can't just be one big sac. That'd make breathing very inefficient. So the primary bronchi, when they enter the lungs, are going to branch out. And I'm going to just look at this in the, from your perspective, the right lung. It's really the left, but from your perspective, it's the right. So the primary bronchi, once it splits into splits called secondary bronchi. Use this one because it'll branch off of that one. That's on the slide as well. All these terms are in the slide. Secondary bronchi. And both of them, I'll just do one, but both of them would split into tertiary bronchi, also on the slide. Tertiary bronchi splitting into bronchioles. I need some more room on here, so I'll write partially inside the lung. Split into bronchioles. The bronchioles splitting into alveolar ducts. And the alveolar ducts eventually ending up at sacs. These are sacs now. These sacs called alveoli. Again, all these terms are on the PowerPoint slide. And once we get to alveoli, that's the end. That's the end of the pathway of air. And to summarize, if we look at the full pathway of air now, from the beginning, this is inhaling. You go from the external or anterior nares, the nose's vestibule, the meatices of the nose, those are in the nasal cavity, the internal or posterior nares, nasopharynx, oropharynx, laryngopharynx, larynx, trachea, primary bronchi, secondary bronchi, tertiary bronchi, bronchioles, and ending at alveoli. This is the pathway for inhaling. Do note the pathway for exhaling is the exact opposite. So I could ask you either something about the pathway for inhaling or exhaling, either way. So be cognizant of that. Last thing about the bronchial tree. So I've drawn it with each split just splitting into two. And there are just two primary bronchi. But for the other branches, there's not just two, there's going to be a lot more than that. So if we look at this bronchial tree a bit more realistically, here's a real bronchial tree. There's a cast made from injecting a bronchial tree with plastic, liquid plastic, letting it set and then dissolving off the lung. So you can see many, many more branches, but the order of the branches is still the same. And that was all for the pathway of air. But there's still some structures to talk about, and I'm going to focus on the last structure in the pathway, the alveoli, the sacs at the end. And for this, I'm going to want a big alveolus to talk about. So I'll talk about alveoli now. To draw this, we'll have the last alveolar duct here going into an alveolus. Make it real big so I can draw things. So there's an alveolus. An alveolus. Alveolus is the singular, alveoli plural. It's a sac. And if you remember from, I think it was the first slide, technically third, I think, but the first with real content. One of the functions of the respiratory system was gas exchange. And so up to this point, we've exchanged gases between atmosphere and lungs, or atmosphere and alveoli. The next stage is exchanging gases between alveoli and the blood. So around this alveolus, there are going to be blood vessels. There's blood vessel. And let's see, is it on the slide? It is. These kinds of blood vessels. Remember from lymphatic system, I said vessels. Those were just tubes carrying fluid. So blood vessels are just tubes carrying blood. Blood go in, blood go out. And this kind of blood vessel, this is a particular name. This is a room on here, yeah. A capillary, which is also on the slide. I'll highlight this. A capillary. I can put this down below so I can talk about this. A capillary. Remember from the lymphatic system, we brought up this term. Capillaries are the smallest, thinnest vessels. We talked about lymphatic capillaries, which were the smallest, thinnest vessels carrying lymph. There's also blood capillaries. In this case, the smallest, thinnest vessels carrying blood. They have to be thin because to exchange gases, we want the smallest distance possible. That's facilitated by having the thinnest blood vessel possible. And so for the exchange, make this a bit bigger for a second. For the exchange, we're going to exchange two gases mainly. We're going to exchange oxygen. For oxygen, there's lots in the alveolus, relatively little in the blood coming in. And there's also carbon dioxide. So carbon dioxide, there's relatively little in the alveolus, but lots of carbon dioxide in the blood coming in. Now, to exchange the gases, the gas exchange occurs purely by diffusion. Now, you talked about diffusion in AP1, Unit 1. And just to remind us, diffusion, that's a chemical going from high concentration to low concentration. So in this case, oxygen is high in the alveolus, low in the incoming blood in the capillary. So blood goes from alveolus into blood. CO2 is the opposite. CO2 in the incoming blood is more, has a higher concentration than the CO2 in the alveolus. So CO2 goes from blood into the alveolus. And this is a good thing because the oxygen, that's going to help us make energy, so we want that in the body. CO2 is a waste product from metabolism, so we want to get rid of that. And exhaling it is easier since it's a gas. Now, for this gas exchange, there's a couple problems that have to be overcome. Make this small for a second. First off, there is the respiratory membrane. These are the barriers the gases have to pass for the exchange. So among the barriers is the alveolar epithelium. Alveolar epithelium, that's just the wall of the alveolus. That's all it is. There is the capillary endothelium. We'll see this word endothelium also in Unit 4. The endothelium, in this case, is just the wall of the capillary. And in between them are their basement membranes. Which, if you don't remember what basement membrane means from AP1, basement membranes, that's just the, actually I'll put it there, I'll put it somewhere else, I'll put it more on the bottom where there's more room. Basement membranes, that's the connective tissue between the membranes. I should say between the alveolar epithelium and capillary endothelium in this case. Those are the barriers the gases have to pass across. Luckily, those barriers are extremely thin, so they don't provide very much impedance. Though they are good for making sure blood doesn't flood the alveolus, which would be very bad. So that's one set of barriers. Now, there's another problem. For diffusion to occur in your body, the chemicals for diffusion have to be dissolved in water. Otherwise, diffusion in the body can't take place. So for diffusion to take place on the inside of the alveolus, use different color, use blue for this concept. inside of the alveolus is a very thin coating of water. I'll use black for the water. So inside the alveolus is a very thin, very, very thin coating of water in the alveolus. So we need that to dissolve the oxygen, especially so it can be exchanged into the blood. But that also causes a problem. And then I'll delete some of this stuff so I can have some room to write. That the water has something called surface tension. And essentially what surface tension is that water is attracted to water. So with this water in the alveolus wall, this water left on its own would try to move together into a single puddle. So the water attracts it, the water molecules attract each other. They try to pull in. And the problem with that is if the water molecules pull in together, the water molecules would pull in the alveolus wall as well. And the alveolus would collapse, which of course is bad because then you're not going to be able to breathe. So to stop the water making the alveolus collapse, we have a chemical also coating the inside of the alveolus called surfactant. Put that highlighted in blue. We have surfactant. So surfactant, I'll put that in here, running out of colors. I'll use green. I'll just put some S's. So some surfactant also mixed in with this water. And a surfactant, as it says in the slide, reduces the surface tension. So we can have the water that we need, but the surfactant reduces the surface tension so the water doesn't make the alveolus collapse. And that's the essential structure of the alveolus. We're going to finish the anatomy in this chapter, but we'll look at this gas exchange process in more detail in the next chapter. Here's a look at a slice through a lung. You can see there's lots of holes in it, which are the alveoli. And this picture is showing the alveoli. I showed it as just one big structure. They're kind of more like this, kind of like grapes at the end of the tubes. And here's a representation of the alveoli being surrounded by capillaries and showing the gas exchange between alveolus and capillary. So now that we've talked about the parts in the pathway of gas movement, now we'll look at the other portions of the respiratory system, starting with the lungs as a whole. So the lungs, first looking at some external anatomy of the lungs. Draw a picture here. The lungs are, roughly speaking, upside down cone shapes. So I'm going to draw out just one lung here, kind of upside down cone shape, something like this. That's a lung. And the lungs, they are held within the rib cage, with the top, and it says here the boundaries. The bottom of the lung is just above the diaphragm. The top of the lung about the level of the clavicles. So extends top to bottom through the whole rib cage. And here are some terms for the external anatomy for the lung. I'll skip hilum for a second and go to the other two first. So base and apex. Base on an organ does not necessarily mean bottom. Base on an organ means the widest part. The widest. So in the lung, in this case, the bottom is the base because it's the widest part. On some other organs like the heart, actually the top would be the widest, so the top would be the base. In the case of lungs, the bottom is the base. Similar for apex. Apex is the narrowest part of an organ. So in the lung, the top point is the apex. Now another part to the lung is the hilum. Now the hilum, this is not the same as the apex, by the way. Hilum is on the medial side of the lung. So if this is lateral side, this is the medial side. I'll use blue for the hilum. So the hilum generically the term hilum, that's an area of an organ where tubes, any tubes for the organ go in and out. So in the case of the lung, the hilum is the tube where the primary bronchi go in and blood vessels pass in and out of the hilum. So this whole part of the medial part of the lung is the hilum, where the tubes go in and out. And we'll see that term hilum in a couple of other places as well for other organs with the same meaning. That's the major external anatomy for the lungs. Now for the lungs, they're divided up into some segments. So they're divided into lobes. The left lung has 2 lobes. Right lung has 3 lobes. So 2 segments on left, 3 on right. The reason the left has only 2 lobes is because the heart is positioned slightly to the left of center. So the heart is pushing a little bit on the left lung, so the left lung has a bit less room. Hence, it only has 2 lobes, not 3. For the right lung, or rather for both lungs, the lobes are divided up into what we call bronchopulmonary segments of a lobe. You don't need to know how many bronchopulmonary segments there are, just know how many lobes there are for each lung. And aside from that, the other major anatomy for the lungs is the pleura. So I'm going to use my lung picture again. I'll erase the stuff from it so I can look at the pleura with all this stuff on here. The pleura, you might have talked about in AP1. I mentioned it very briefly in my class. Let's see, I mentioned it in Unit 2. We talked about membranes, epithelial membranes. But not in much detail. So I'll go into detail here. The pleura are membranes around each lung. And I say each lung because the left lung has its own pleura and the right lung has its own pleura. So say we'll just take this as one lung. And the pleura, there's 2 layers. So I'm going to draw, what color do I want to use for this? I'll use black. So around the lung is first one layer of pleura. That's a membrane. And this is 2D, so it's not shown. But this first pleura surrounds the entire lung, front, back, sides, everything. And this first pleura is called the visceral pleura. Viscera are organs. So visceral pleura is the pleura that's touching the lung. Touching the lung. Now, there's another pleura outside the visceral pleura, which I'll draw in blue. So outside the visceral pleura is another membrane around it, all the way around, not touching the lung. And that second layer is the parietal pleura that is not touching the lung. So 2 layers of membrane. And in between the 2 pleura, in between, there's a whole bunch of fluid, which I'll represent with this green, these green dashes. Whole bunch of fluid between the 2 pleura. This fluid is just called pleural fluid. Okay. Now, what's the whole reason for all this setup? This is actually a very important set of structures. Because if you think about this, when you breathe in and when you breathe out, your lungs will expand when you breathe in and contract when you breathe out. So your lungs with each breath are going to expand, contract, expand, contract, expand, contract. Roughly a dozen or so times each minute, every minute. And if you think about that, since the lungs are inside the body, just by themselves, the lungs, when they expand, would scrape or rub against the inside of your body wall, which would make friction, which would hurt the lungs. And if you're doing this at least a dozen times a minute, every minute, it wouldn't be too long before those lungs are ground up into nothing. Or at least to get the first initial hole in it. And so this is where the pleura come in with their fluid. How this works, because there's fluid between the two pleura, when the lungs expand, the two pleura slide against each other without any friction. The fluid prevents friction, like oil in your car. So without friction, when the lung expands, the two pleura slide across each other, no friction, no damage, the lung doesn't get hurt. And that is the whole point of the pleura. We'll see a similar system in Unit 4 when we talk about the heart, and Unit 5 when we talk about the abdominal organs. But that's the pleura. And functions of lungs, 2 of the 3 we talked about at the beginning of the PowerPoint. Air distribution, you get exchange of air between lungs and atmosphere. And also exchange of gases between lungs and blood. And so I think I have a picture. Yeah, this picture is showing the lungs inside the rib cage. And you can see this is colored in. The left lung, which is on your right, the left lung has 2 lobes. The right lung has 1, 2, 3 lobes. That was the lungs. Now, a bit about the thorax in general. Remember, thorax, that's the part of your body where the ribs are, between the top and bottom of your rib cage, or we could say below your neck and above your diaphragm. Maybe we'll put that on here. Thorax, we could say from top to bottom of rib cage, or we could say below neck and above diaphragm. The description works. And for the thorax, have some structures. I just talked about the pleura. But in the thorax, there are 3 cavities in the thorax. 3 cavities. So let's see. Start with black, I guess. So I'm going to draw out very roughly the front of a person. That'll be the neck. Let's see. Some arms. And some legs. Okay, there's a person. And so first off, a person is divided, the torso is divided between the abdomen, or if you want to be fully inclusive of all the parts, the abdominopelvic cavity on the bottom. And I'll cut off this arm for a second. Actually, I'll just cut off the arms entirely. And the thorax on top. And inside the thorax, we have 3 cavities, which I'll outline in a few different colors. First, I'll make a red here. Let's see. Just make kind of a square here. This is very rough positioning, but it's fine for this. I'll make that square actually a bit lower. I'm not going to try for exact positioning here, actually. So there's a cavity there. I'll put 2 cavities on either side in blue. Put P, the letter P inside them. And letter M inside the red one in the middle. So 3 cavities. The 2 cavities in blue with the P are the pleural cavities. So pleural cavities, these are the cavities that contain the lungs, the 2 pleural cavities. And the cavity in the middle with the M is the mediastinum. So mediastinum is between the 2 pleural cavities. And a major organ inside the mediastinum is the heart. That's in the mediastinum. For the respiratory system, however, mediastinum also contains the trachea as well. Those are the major cavities of the thorax. And now that I've talked about all that anatomy, last are some disorders. So I divide these up into groups. These are disorders of the upper respiratory tract. The first 4 are all infections. And remember, infection has that itis, and usually the name tells you where it is. So first off, rhinitis is infection or inflammation of the nasal cavity, or some might say the nasal mucosa. I've seen both descriptions. That's what that R-H-I-N means. Rhin means nose. Like a rhinoceros, that means nose horn. Ceros, horn, rhino is nose. Pharyngitis, I should put here infection. Pharyngitis, infection of the pharynx. Laryngitis, infection of larynx. Tonsillitis, talked about that in last unit, infection of tonsils. So names tell you about those. Some other disorders that aren't infections, deviated septum. Now remember, the septum, that's the part of your nose dividing it into left or right, left and right nostrils. So deviated septum, the nose septum is positioned too far right or left. And this will obstruct one of the nostrils. Secondly, sleep apnea. This is when people stop breathing during sleep. And you might be able to even diagnose this if you sleep with someone next to you, because if people have sleep apnea, they oftentimes will have loud snoring. So if someone snores loudly in your house, possibly you might need to get that checked out, because it could indicate an underlying, more serious respiratory problem. And last, for the upper tract, epistaxis. That's the fancy name for a nosebleed, epistaxis. These are major problems with the upper respiratory tract. Now for the lower tract, some infections. Bronchitis, name says it, infection of bronchial tree. Second, pneumonia. Pneumonia is a lung infection. Oftentimes, one of the symptoms being excessive mucus production, among various other symptoms. And tuberculosis. Tuberculosis, this is a bacterial infection. And a major symptom of tuberculosis, where the name comes from, the bacteria form lesions, also called tubercles in this case, which lead to making scar tissue on the lungs. And last major disorder, the lung cancers. Of course, lung cancer impedes breathing. And for lung cancer, this is one kind of cancer where surgery is often one of the major treatment options. And surgery, we can do this on the lung partly because we can cut out individual lobes of a lung, individual lobes or bronchopulmonary segments. And because of that, because the lung has these divisions, if you cut out a lobe or a segment, the other parts are not necessarily affected by that loss of tissue. Overall, that lung would be less efficient, but it would still be able to operate, which makes surgery somewhat convenient, at least in terms of relative ease of treatment application. And that was chapter 35. Next up will be chapter 36.